this week on the BackTable podcast.
Remember a couple other things for a new adopter who's just trying to get started, or maybe somebody fresh out of training who doesn't have, the luxury of a robust profit and loss and a lot of money coming in. This is where you leverage your industry partners. You literally say to them, listen, I want to get started. I need your help. I need you to bring in a demo for me for my first 5 cases. And I need you to let me try a couple cases with your balloon to make sure that this is something. So, you get a couple cases, and that's part of trialing the balloon, right? You get a couple free cases to check it out, decide which technology you want to use. They'll bring in a camera for you to demo. They'll bring in a tower. I mean, they'll bring in the mini fest set for, 3 or 4 cases. So highly recommend doing that. It'll generate some income. It'll generate some confidence. And then it'll allow you to really fine tune what you like, what you dislike, what you're looking for, kind of for a more permanent fix.
Hello, everyone, and welcome to the BackTable ENT podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice.
And now a quick word from our sponsor, Stryker. Stryker's ENT solutions offer the control you need, the flexibility you want, and enable you to deliver the experience your patients deserve. With Stryker, you gain access to the most complete suite of solutions to help make your vision of patient care a reality. From technology to training, from reimbursement tools to patient education, Stryker is there to help. Together with their customers, they are driven to make healthcare better. Learn more at ent.stryker.com.
My name is Gopi Shah, and I'm a pediatric ENT here in Dallas, Texas. And today I have 2 very awesome guests on a great topic. I have Dr. Ashley Sikand. He's an otolaryngologist at Nevada Sinus Relief in Las Vegas. His focus is on the diagnosis and management of sinus disease and nasal disorders of the nose. He's an expert in endoscopic sinus and skull-base surgery, as well as a pioneer of office-based, less invasive techniques. We also have Dr. Brian Weeks, who's an otolaryngologist at the SENTA Medical Clinic in San Diego, California. He specializes in sinonasal disease, sleep, and thyroid problems. And they are here today to talk to us about in-office procedures for nasal obstruction. Welcome to the show, guys.
Awesome to be here, Gopi. Thanks so much for having us. Really, really excited to be here.
Yeah, thank you.
Can you tell us a little bit about yourself and your practice?
Yeah, I'll start off, Ash. Brian Weeks. I think one of the neat things about my practice and my journey in otolaryngology is that I'm a 2nd-generation otolaryngologist. So I was able to join my dad in practice, and my dad's currently been practicing, in some sort for 52 years. So he started SENTA Clinic 52 years ago. And, it's been a really special time, and it's made all the innovations and all the things that we're doing differently that much more impactful, because my dad, I have it from my perspective and then also from my dad's perspective. So yeah, I really love it. So happy I'm an ear, nose, and throat specialist. I almost went into plastic surgery. I was thinking it would be cool to be a heart surgeon. And I thank my lucky star every day that I chose ENT.
Great. Thanks, Brian. I think one of the unique things about my practice is that I'm in a 9-physician single specialty ENT practice here in Las Vegas. And the practice has existed since 1968. My practice is focused on doing office-based rhinology. I also do outpatient rhinology at the surgery center, but I sort of evolved that way since about 2007 when we first started doing in-office cases using balloon sinus dilation, and have been really fortunate to adapt those exciting and interesting new technologies to help patients in a new venue and collaborate with other physicians like Dr. Weeks and so on across the country. So that's been an interesting and evolving journey over time.
How did you find yourself specializing in office-based procedures? And is that kind of how you guys began working together?
Yes, on both fronts. With the advent of balloon sinus dilation technology, I was, I think, an early adapter. And one of my mentors, Dr. Winston Vaughn, was involved in the first in-man studies for balloon sinus dilation, and got me interested in using the technology first in the hospital and then the surgery center. And when it switched over from using fluoro techniques to transillumination, I was able to think about bringing it to the office. And then I collaborated with another eminent rhinologist named Michael Sillers in Alabama, formerly president of the American Rhinological Society, and writing the first paper on in-office balloon sinus dilation techniques. And then got involved with other colleagues like Dr. Weeks in presenting and developing something called the Sinus Forum, and also collaborating and writing a number of research papers. and expanding the use of techniques in the office to help patients without requirements for hospital or general anesthesia. So I'll let Dr. Weeks comment further on our collaboration and his journey as well.
Yeah, I mean, it's such an interesting reflection, but I think the first thing I learned is when something comes across your bow, don't be closed-minded, be open-minded. I'll just tell a quick story. It's actually quite funny. I'm in my office. I'm just starting in practice. This is in late 2006. I'm working hard and I'm there late at night. And we'd had some break-ins at the hospital where our old office was connected to the hospital. And there were some break-ins. And so I'm sitting at my desk. I was always the last person out of the office. And I hear somebody walking in the hallway. And I'm like, okay, nobody's supposed to be here. I know I'm the only person. So I had a baseball bat in my office. So I picked up the baseball bat and I have the baseball bat cocked back, as if somebody's coming to try to steal from me. And I have it cocked back. And this guy walks into my door and he's obviously like a professional guy, dressed in nice clothes. And I was about to swing the bat at him. And I go, yeah, what do you want? How can I help you? And he goes, I'm looking for Dr. Brian Weeks. And I was like, okay, well, yeah, I'm Dr. Brian Weeks. And he goes, hey, my name's Tom O'Neill and I work for a small startup company called Acclarent. And I was like, okay. So anyway, so he gives me a brochure and he goes, we created this technology to treat sinuses. And I said, okay. I mean, I listened and it immediately sounded like, wow, that sounds like a really cool idea. We all knew about angioplasty. So the long and the short is I got invited to go up. I ultimately became a member of the scientific advisory board of Acclarent right after the CLEAR study came out. But I was on the board with Howard Levine, Mike Sillers, Ray Weiss, Pete Catalano, Fred Kuhn. I mean, all these eminent rhinologists around the country. And, so that was one of the first lessons I learned was don't poo-poo new technologies just because you don't know anything about it. Be open-minded. And then the second thing I'll tell you, it's really funny, is after we had developed a couple technologies within the balloon platform to allow us to be more successful and even less invasive and less cumbersome, we decided to do this study called the Oreo study. So I remember I was recruited like the first patient for the Oreo study. And we did this case in the office. And it was like this woman with an isolated frontal sinusitis or chronic frontal sinusitis. And we had all this equipment and we knew nothing about anesthesia. We knew nothing about, the way to do this. And this case was awful. It was like, it took like 2 hours. I had like 5 people in the room with me. The patient was screaming and it was one of those miserable experiences. And so those are 2 really interesting reflection points for me because it's sort of the beginning of these journeys. And now we can do 6 or 8 or 10 office cases in a day seamlessly. Patients feel nothing. It's just a really cool way to reflect on the journey. But yeah, Ash and I have been able to work together on quite a few studies and papers and courses. And we run a couple of courses now, every year in Vegas. And so it's been an incredibly rewarding journey.
Those are great reflection points for sure. How do you keep going? I mean, it's very easy to be discouraged when you have a case like that, whether it's obviously in the OR, but much more in your clinic when the patient's awake.
Yeah. I mean, I'll start and Ash, I'm sure you can share, some wonderful anecdotes as well. I think those types of adversity either strengthens you or it defeats you. And the way I looked at it was I felt like we were really doing something great. I mean, one of the things that we learned after the Oreo study was done is that we were delivering something that had a real place. I mean, is balloon sinuplasty for every patient? Of course not. Is it for appropriate patients with disease that's amenable to that? Yes, it is. And there's a large body of patients. But I guess what energized me was the fact that I felt like we were doing something significant that was ultimately going to change the way medicine was practiced. And that was compelling enough that it made it worthwhile. So that for me, that was the light was that we were giving back something to our field.
Yeah, I think I'll say that a key point that I'd like to emphasize for my colleagues is that you're never alone in your quest to improve patient care and advance through challenges and achieve better results. And by that, I mean, I was always fortunate to be surrounded by colleagues I could reach out to across the country, and Brian being one of them, but he's mentioned a number of others. And in addition to that, you build your own team here, right? So everybody from physician assistants to medical assistants to office managers and so on. So you're all working as a team. You may be sort of quarterbacking it, but it's important to have all of those elements and, they foster better care for the patient. And then finally, I think we all owe some gratitude to our patients for, in Brian's anecdote, putting up with our first procedures in the office and in whatever element or area that we're trying to progress and encountering some challenging situations. So I think all those combinations keep us motivated. Our friends, our colleagues, the nurses and people we work with, and then, of course, the patients that we're trying to help.
Yeah, it's great. So I wanted to talk specifically about in-clinic or in-office procedures specific for nasal obstruction. What are the different procedures kind of fit that group? What are the procedures that are in clinic done for nasal obstruction that you do?
Maybe I'll start with one of the more common causes of nasal obstruction that I've been interested in kind of working with and treating in the office, and that's deviated nasal septum. So a lot of people did septoplasties under local anesthesia back in the 1950s and 60s. And, Dr. Weeks' father may have remembered those days in his training as well. We kind of, I think that's encountering a resurgence now with better local anesthesia techniques and minimal sedation techniques. So we can do it in the office. I became interested in that because a lot of my patients may have had sinus disease, but they also had nasal obstruction, frequently from a deviated nasal septum. So I found that interesting, at times challenging, but the focus has always been on providing a proficient procedure with the patient having not only a good outcome, but a good experience. So not encountering the discomfort. And that relates to our meticulous anesthesia technique that, we owe a debt of gratitude actually to our colleagues in oral surgery and dentistry. I read the early papers there about blocks and the type of anesthesia that's used. Sphenopalatine blocks, some of our early pioneers in ENT. I use that, and I essentially use that almost on every patient that I do in the office. And then sort of an evolving science of minimal sedation, or not true conscious sedation, but sort of anxiolysis with some pain management that I think is continuing to evolve. So the septoplasty, I think, is in many cases, is very amenable to the office. Not all cases. In severely deviated septums where you can't even get close to doing a sphenopalatine block, I don't recommend it. But we've been able to do a large series that we'll be reporting on shortly. So that's one thing I definitely would encourage people who have had some experience with in-office to consider a septoplasty as well.
Yeah, I can add, I think, to dovetail on that and complement it. The other, I think, area that we're really seeing, kind of a rebirth, if you would, is dealing with the nasal valve. And, first off, when I was in my training, I trained at the Baylor College of Medicine. I'm proud. I had a wonderful training, great county hospital. And I'll absolutely second what Ash said about the oral surgeons. I mean, our clinic and oral surgery were back to back. So we had a common hallway. We would also cover facial trauma with plastics and oral surgery. And those guys would basically do mandible fractures in the clinic. And I would go down there and I learned, there was a doctor named James Johnson, who was an older oral surgeon who was retired and would come and teach the residents. And I learned so much from that man about how to anesthetize the lower jaw and the upper jaw and the dentition. And so, yeah, that's made, the office journey that much easier. I mean, the other thing that I would say about anesthesia, particularly with nasal surgery is, go back to your textbooks and understand sort of what you're trying to achieve. I mean, I went back and reviewed the anatomy of the trigeminal nerve, specifically V1 and V2 for the nose. And you think, oh, if I just do this, block this, it'll work. But specifically, there are very, very small branches that you can block kind of tactically, and it achieves incredible anesthesia. But for the nasal valve, I mean, honestly, the biggest thing that's advanced our ability to treat that is, first of all, awareness, and secondly, technology. And with technology breeds awareness. I mean, when I was in my training, the only people that dealt with the nasal valve were the facial plastic surgeons. And they would do batten grafts and, spreader grafts. And it was a kind of a big deal for the patient. And, you're kind of like, wow, I don't know if I really want to be doing that. I'll just send those to the plastic surgeons. And so for that, it's kind of like eustachian tube dysfunction. I mean, I can't tell you how many people I've seen for eustachian tube dysfunction who come to me and say, I saw my ENT, I saw 3 ENTs and they told me there was nothing wrong. What that really means is we don't have anything to do for you. So, sorry. But now that we have these amazing treatments that are very amenable to local anesthesia and, really office-based therapies, I mean, I think there's been an emergence. And clearly when you review the current literature and look at quality of life scores and nose scores and things like that, you'll see that addressing the nasal valve as part of a triad of nasal airway obstruction, anatomic issues is really, really impactful on improvement in breathing.
And so I want to get into the anesthesia portion as well. But before we get to there, we've talked about deviated nasal septum, nasal valve, and I would imagine probably a lot of turbinate obstruction in terms of nasal obstruction. What else? Am I missing other? Because when I think of nasal obstruction, those are kind of the three that I think of, but I'm sure there's other things I should be thinking of.
Yeah, I think I can just add and ask if you have anything else. But, obviously things like nasal polyps, polypoid nasal obstruction, and then, even things like just, the effects of chronic rhinitis conditions, things like that. I mean, we have the ability to effectively treat all of those diseases in the office. And I think, specifically with polyps, I think most ENT doctors that have an office-based platform have a microdebrider in the office. I mean, we use our microdebrider every single day in the office. And it's not uncommon to remove a large burden of polyps in the office. Interestingly, I was just having a conversation at the course here in Scottsdale, and it's actually far easier to remove nasal polyps in the office than in the OR because there's really no bleeding in the office. And I know that sounds crazy, but the patients aren't vasodilated and there aren't, there's no lability in the blood pressure. And these are essentially avascular procedures. Ash, I mean, you do a ton of ethmoidectomy and nasal polypectomies as well in the office. I mean, I'll let you speak to that, but would you agree?
Yeah, absolutely. And, I started getting very interested in office-based procedures because I got a lot of referrals from pulmonologists whose patients have COPD and other chronic conditions that make it difficult for them to undergo general anesthesia. But they can't breathe through the nose because of, in many cases, nasal polyps or hypertrophied turbinates, very large or expanding concha bullosa that becomes infected. So these conditions are all amenable to being treated in the office and with significantly less risk or morbidity than doing them under general anesthesia. So agree 100% with you, Brian, on that. So I think we've sort of dealt with the panoply of nasal obstruction etiology there by adding the polyps and perhaps concha bullosa and turbinate hypertrophy, chronic rhinitis. All of these are challenges and very common conditions that we deal with. And, I also agree with the fact that the advent of newer technologies actually make us more aware of some of these problems. And, a simple example is the development of nasal endoscopy to be able to refine our evaluation of the nasal airway and perhaps emerging technologies that allow us to scan the nasal airway, determine sites of obstruction, and become much more precise in developing a treatment paradigm for managing those conditions.
So when these patients come, do you feel like you do everything on like one single procedure day? Or let's say for the person that's just starting out that may not be able to fill a half day or a day of procedures, should they just block a morning and have that one patient? Or do you know people that, they see patients in between and then kind of have an hour in between in the mid-morning for a procedure? How does the scheduling work? Or is that just physician dependent on what they feel works in their practice?
I'll go first, but it's good to have two of us here, so we probably do things a little bit differently. And that's also evolved for me as well. I think when I first started, I had one afternoon a week because the number of patients I selected was less because I wasn't doing things like septoplasty and so on at that time. But now it's kind of changed. I do half days. So I do 4 half days a week in which we do office procedures. And then all I do during that time is focus on the case at hand. For me, it's easier patient flow. I use 2 rooms to do that. And so one room serves as a pre-op and post-op room, and the other is the actual procedure room where I have everything set up. And that flow works well for me. We have a team that usually consists of my medical assistant, sometimes my physician assistant helping me. And then frequently we have either medical students, residents, or visiting otolaryngologists from other parts of the country observing as well. So that's how it's evolved for me. I'll let Brian describe his office flow.
Yeah, Gopi, Ash, I love it. I think it's great the way you're doing it. What I would basically say to anybody who's contemplating, getting started or trying to figure this out is, right at the beginning, definitely err on the side of giving yourself a little bit of extra time, because what'll end up happening is if you feel rushed or if things don't go as smoothly as expected, you don't ever want to feel that time crunch. When I started out, I was bouncing between my office and the OR, on the same days. And what I found was I was always either late to one of the places and I was always stressed. So I would advise, when you're starting out, book an extra hour, maybe more than you think you need at the beginning. And ultimately what will happen is I think as your volume grows and as your confidence grows, your volume will grow. The patients are there. It's just a matter of you kind of finding out that you can actually do as much as you want to do in the office. And as long as you're, being sensible and just growing your confidence. That will naturally be how things transpire. And then, I think from efficiency's sake, we have a pretty streamlined process, just like Dr. Sikand does, where we have our PAs and our MAs working. We have, a really good patient flow. So I can, frequently have a patient anesthetizing, and I'll be seeing a pre-op or a post-op or a new patient in between. And that's where the efficiencies come in. And for my practice in particular, I have dedicated full days in the office, and I either do 1 or 2 full days a week. And then I have dedicated days in the hospital or surgery center. And then I have dedicated days where I just see patients. The caveat to that is I consider office procedures as sinus and eustachian tube dilation and lateras. And I don't consider Clarifix as a procedure that I do frequently. And that's just rolled right into my normal patient flow. So those patients are not part of a procedure day, because Clarifix is very, very quick. After the anesthesia, the procedure takes me about 7 or 8 minutes total time in the patient room.
Okay. Just because I'm not as familiar with those. The Latera is the nasal valve device, and the Clarifix is, I apologize, I don't know what the Clarifix is.
No, it's no problem. So I'll tell you exactly. So Latera is the lateral nasal wall implant, and that is the stabilizing implant that stabilizes the internal nasal valve. And it's made specifically for dynamic nasal valve collapse. And yeah, so it prevents that or improves that. And then Clarifix is posterior nasal nerve or postganglionic branches of the sphenopalatine cryoablation. So it's the freezing, and there's other technologies too. There's a competitive technology called Rhinair, and then Latera's kind of competitive technology is something called Vavair, and that's more, in my opinion, ideal for static nasal valve hypertrophy as opposed to dynamic nasal valve collapse.
And then in terms of the deviated septum in the clinic, is it more for that posterior nasal spur that you can kind of cut down on, or describe which, I mean, I would imagine the super twisted, crooked, that's kind of out in the front, probably not. And is there a device for this, or is it the standard numb them up, create the flap?
Yeah. So when I'm talking about septoplasty, I'm talking about a full septoplasty with, either a hemitransfixion or Killian incision, elevating mucoperichondral, mucoperiosteal flaps, and treating whatever needs to be treated with the vomerine bone deviation or deflection, as well as the caudal septum, dealing with the cartilaginous deflection as well. So I'm talking about a standard septoplasty. The caveat there for doing the office is you have to be able to endoscopically get back to the region of the sphenopalatine nerve distribution in order to block it. So I usually place my block medially, fairly close to the posterior nasal septum, and let the local anesthesia migrate laterally, and it includes the nerve. So if you cannot do that, then the patient's probably not a good candidate for doing the office, because that sphenopalatine block beautifully anesthetizes most of the nasal septum. And you need that on board, not only for local anesthesia, but also helps really minimize any bleeding. But then you have to do infiltration of the caudal septum as well separately. So I rely on sort of what I call back migration of the anesthesia. So injecting the mucosa, and then the anesthetic effect will backflow to the very anterior caudal septum, and you get good anesthesia before you actually undertake it. The whole concept of just a spur and you just take that off, that's pretty easy. And that's been done before with just elevating a flap, taking off with Takahashi or whatever. So I don't really consider that a full, you can bill it as an endoscopic septoplasty, as we all know, appropriately so, but that's not, when I talk about doing the septoplasty, I'm talking about doing something more on that. There have been, I think, some tools developed for septoplasty and other options. I'll let Dr. Weeks maybe comment on all of that.
Yeah, I mean, I've actually been with Dr. Sikand for his septoplasties. He does a full-on subsection septoplasty. And I do it too. I probably do fewer septoplasties in the office than Dr. Sikand does, but I still do quite a few. And then, yeah, as far as devices developed to help us with septal surgery in the office, there's really one device that I know of on the market right now. It's called the Tract balloon, and it's made by Acclarent. It's actually a very, very good device for the right type of nasal air obstruction. I think the only issue there, Gopi, is that there's really not a code to bill for it. And it's not an inexpensive, it's not a ridiculously expensive device. I think it cost about $400 or $500, but it's not something that we really have a code for. So you can't bill for it. And I think that does make it a little bit challenging, just as we think about the office and the expense to the physician. But as an access tool for someone who's not comfortable doing septal surgery, but wants to maintain those patients in an office setting, it's actually a useful tool as a complementary device to the other platforms that we have.
And is that then kind of pushing the swell body out, or does it actually kind of make like a mini fracture along the cartilaginous? How does that work?
Yeah, it's a great question. The way I could describe it for people that don't know, most people are familiar with the airway balloon that have used for like subglottic stenosis, things like that. It's very similar in its design to the airway balloon. It's a high pressure, non-compliant balloon, and it actually does fracture the vomerine bone. And it also effectively outfractures the inferior turbinates. So you get that duality of treatment. But yeah, it's meant to actually microfracture or fracture and reposition the septum. I think the difficulty is that it's effective when you have something going on at the maxillary crest. You can sort of fracture the crest over. It's not a great tool for cartilage simply because cartilage has memory, right? And you dilate it and then it just gradually creeps back over, hours to days. But I think it's effective dealing with kind of bony cartilaginous junction issues, certainly spurs, and then maxillary crest deformities. And if you fracture those structural areas over, the cartilage frequently comes with it.
So this is not an in-office question, but just a personal question. Doyles or no Doyles? Splints after septoplasty or no splints after septoplasty?
No splints for me. I think that the patients that have had them just always report they're really uncomfortable.
So I do place Doyle splints, but I take them out the next day. So it's just overnight. I done it without them, but I guess personally we got some more callbacks on those patients that were having some bleeding. Not anything that one would put packing in for, but it was more annoying than if you put in the splint. So they'd call me, and it gives me an opportunity to check the patient the next day, just counsel them again, and make sure they're in the right treatment plan with the rinses and so on. So
full transparency, Gopi, I actually do put packing in the nose on most patients. I put a laminated Miracell sponge and I take it out the next morning. So it's in for anywhere from 16 to 20 hours and it's very tolerable. And most of the patients are still kind of under, they're sleepy from their anesthesia or so. So it's really not cumbersome. But, the Doyle splints, I've heard from a lot of patients, they're hard, they're uncomfortable. And they really, after most people leave them in about 5 days, that's really uncomfortable.
Yeah, I think that. So it sounds like we're actually. This is something I didn't know about your practice is that you place the Miracell kind of. It's pretty similar. We both take them out in within 20 hours.
And it sounds like it's more for hemostasis than it is to kind of hold anything in the middle, if you will.
For me, it's for hemostasis mostly. Yeah.
All right. So going back, we talked about blocks, some anxiolytics. Do you have like a anesthesia protocol, or does it depend on, okay, I know I need to do the SPA for my septoplasty, but I might be blocking something different for the Latera valve splint or implant?
Right. So I think we talked about this, Dr. Weeks and I, some of our courses we presented together, but we have very similar protocols, but they do vary a little bit. There's some variation depending on what procedure we're accomplishing. So it's definitely a little different if you're doing Clarifix or Latera, which will require a different type of anesthesia protocol. But I'll just comment on my anesthesia protocol for sinus work, whether it's balloon dilation, polyps, as well as for if I'm doing septoplasty or turbinate work. I guess it can be divided into 3 sections. The first is, what do you do for anxiolysis? So that's number 1. And number 2, what do we do for surface anesthesia or topical anesthesia? And third, what type of infiltrative anesthesia protocol do we have? So just briefly, for anxiolysis, I'm like Dr. Weeks, we're in states that have pretty significant and clear guidelines, or state boards do, on what type of anesthesia or what type of anxiolysis we can deliver in an office setting. And that, we conform to that because the American Society of Anesthesiologists looks at minimal sedation or anxiolysis in the same section, and that is not considered to be conscious sedation. So the patient is verbally responsive. He or she can protect their airway, and there's a minimal cognitive impairment in those patients. So an example would be if you provided somebody with a triazolam or lorazepam, relatively low dose, like a sleeping pill, basically. And so I use lorazepam, and typically I use 1 milligram. Occasionally in younger patients who I feel have a little higher anxiety, I'll use 2 milligrams of lorazepam. And that's equivalent to 5 to 10 milligrams of Valium in that zone. Then I typically have not used any opioids, but recently, and I'll let Dr. Weeks comment as well, we were trialing a rapid onset sublingual opioid that does not cause respiratory depression. And I think in certain settings, in certain situations, that'll also be quite helpful in providing that type of anxiolysis for the patient. Moving on to surface anesthesia, I really emphasize it. So I spray the patient's nose with our lidocaine and neosynephrine mixture, 4% lidocaine, and a 50-50. Then I place pledgets, the same mixture. And then most importantly, I use polycaine gel. And that is a very potent topical anesthetic, 6% polycaine gel. And I place it myself with a blunt needle under endoscopic guidance on all the areas that I'm going to be touching, really. It doesn't take very long. Maybe the application probably takes them like 2-3 minutes total, and it works very rapidly. And after that, I find patients do not have a problem with my next step, which is infiltrative anesthesia. So depending on what I'm doing, if I'm doing septoplasty work, turbinate work, or any significant level of balloon sinus dilation, other than just say if I'm working on an isolated frontal sinus, I use sphenopalatine block. Then also infiltrate the middle turbinate and superior to the middle turbinate as well as the inferior turbinate if I'm working on that. So I still don't use very much actual infiltration. Even when I'm doing a septoplasty, I'd probably say 10 cc's or less of 1% lidocaine with 1 in 100,000 epinephrine or 1 in 200,000 epinephrine for patients who may have some cardiovascular issues. So my patients are monitored with their O2 sats and their heart rate. And that's protocol that we've been using now for over a decade. And I think if you set expectations, really communicate with your patient, communicate with your team, develop a great team, and create an atmosphere that puts the patient at ease. We have music playing in the background. Patients that want to use headsets, they can, things like this. And I think that really makes for the best office-based experience. So I'll let Dr. Weeks comment on any differences he has in his anesthesia technique, plus how he manages the Clarifix and Latera patients.
Yeah, thanks, Ash. That was comprehensive. And I mean, Dr. Sikand's a master at topical anesthesia for sure. I think, our protocols are very similar. I use actually 2 milligrams of Ativan. The thing about benzos in particular is that they're incredibly safe. There's zero risk of respiratory depression. I mean, literally, you can give it in the oldest patient and they'll be very, they'll look like they had way too much to drink at the party, but they're never going to stop breathing and they don't have any problems with those types of catastrophic things. So they're very safe. I use those in conjunction with a similar topical and infiltrative. I use just liquid 4% tetracaine mixed with oxymetazoline, and that works really, really well. But I would agree tetracaine or ponticaine is the workhorse anesthetic in office procedures. As far as Latera goes, again, I anesthetize the vestibular, kind of alar vestibular junction inside the nose with some topical, either tetracaine gel or tetracaine soaked cottonoids, sort of for about 10 minutes. And then when I come into the room, the patients had their anxiolysis medications before, and we have the patient take those about 2 hours before their procedure. Then when they come into the room, after I've removed let the gel work or remove the cottonoids, I do V2 blocks. And really the emphasis of the V2 blocks is the lower part of the canine fossa injection. So I don't go all the way up to the infraorbital frame, and I go about halfway up and then I inject. And really what we're trying to do there is we're trying to get the lower perforating branches of V2, and then we're trying to get the septal branches, which is what innervate the alar rim and the internal vestibular mucosa. Once you block those effectively on both sides, then the last part of the injection is you actually have marked the nose where you want your implants to sit, and you infiltrate the tract of the implant. And the key with all this, the reason you're doing the V2 blocks is so that they don't feel those injections in the ala and in the tract, because those are quite uncomfortable. And, I go back and forth with my colleagues. There's a guy who's an otolaryngologist in Texas named Jose Barrera, who's a very gifted guy. He's a facial plastics guy. And Jose and I go back and forth all the time on local anesthesia for Latera. He's a big supratrochlear guy. So you have to block branches, supratrochlears off of V1. But I always say it's one of the most uncomfortable blocks and there's no way to numb it up. So, you can do it that way too. And V1 provides a lot of surface anesthesia to the nose. But either way, once you've done those injections, I mean, literally the patient feels nothing. We use double skin hooks to provide counter traction as we're placing our implants and finding that sweet plane. And the patients don't feel anything. You can literally do your procedure without any concern for the patient being uncomfortable. And the procedure itself is extremely quick once good anesthesia is achieved. And then Clarifix, it's really topical tetracaine throughout the nose more generally, and then focally at the treatment spot. And it takes about 10 to 15 minutes. The key with local anesthesia, if I was giving anybody just starting out, kind of one take home high level message, it would be, don't be in a rush. Let the anesthetic work. If you give it time, if you let the tetracaine sit in the nose becomes extremely numb and you can really, you can do very well. And if the patient's uncomfortable, the doctor's uncomfortable, and it's a miserable experience. So let the medicines work for you.
Yeah, it's funny because in the OR, when we're, for afferent plugits in the nose, I have to tell whoever I'm with, make sure we're not putting anything in the nose unless we've been 5 minutes by the clock, because I get so okay, let's go, right? And so you have to give it time. In terms of hemostasis, you mentioned oxymetazoline plugits, and I would imagine some of the with infiltrative anesthetics also. Is there anything else in terms of hemostasis? I think you also mentioned that when they're not under general anesthesia, in terms of blood pressure and things like that, and they're calmer, that's also to our advantage.
Yeah, 100%. Again, something that might seem counterintuitive is that office patients that are awake they really don't bleed very much. It's really surprisingly, it's shocking in a way, but definitely people should believe that because it's true. I always have a couple of different hemostatic agents in my office. I have Hemopore, usually have at least one, kind of container that I can mix of either Surgiflow or FlowSeal. And it's really, those are for very unique or unexpected situations. And then I have, nasal packing, gel foam, Miracell sponges in my office, and then the last thing we have is, we have cautery available. We have bifurcators and suction cauteries available. I was telling the group today with the course I'm at, the group I was speaking to, that you can get a used Valley Lab cautery machine on eBay for like $200. So it's pretty funny, but you could literally have a cautery in your office tomorrow for a couple $100. And it's pretty much a good idea to have that just in a case of a rare emergency. You barely ever use it. I don't even know when the last time I've used it is, but just to be prepared.
Yeah, I would agree with all those comments. I also use topical epinephrine on cottonoid plugits. And I found, for example, if you're doing ethmoid work, you work on one side, particularly those patients. The one caveat where you do get some bleeding is a really inflamed sort of osteomiddle complex in those patients who have dental infections, where the pus has been in the sinus for a year or more, and it's very inflamed. And so I mean, it's not like there's a lot of bleeding, but you want to mitigate any using. So I find these the use of topical epinephrine 1,000 on cotton plugits has been very helpful in that situation. And of course, the more meticulous you are with your local anesthesia, the better your hemostasis is going to be up front. So that's another take-home point, just, sort of backing on to what Dr. Weeks said.
In terms of patient selection, I guess the question is, what are the red flags, or who are the patients that you just can't do this? Or disease, when is the disease so bad that you just are like, nah, we should do this in the OR?
Right. So I think in your question, you touched on the two, sort of the bifurcation of patient assessment or patient selection, right? So one is the focusing on the patient's sort of psychology, sort of personality inventory, if you will. The patient who just has a tremendous amount of anxiety, doesn't do well at all on any kind of dental procedures or cannot do that, and is very, very apprehensive about even your nasal endoscopic exam. So that is a subgroup of patients that may not be appropriate for this kind of a situation. I've found that our older patients do extremely well in the office. And that's fortunate because they also may have more problems with general anesthesia, right? So they do very well. Some younger, high anxiety individuals, I think, are a little bit more problematic. Then on the other side, the type of case, I think there are two considerations there. One is definitely the number of procedures that are going to be performed. So if you're going to fix the deviated septum, but you also take out a reasonable number of polyps and an ethmoidectomy and do balloon and sinus dilation, and the procedure might be a little too long for an office-based case. So those are the kind of considerations. And I think a lot of it has to do also with your experience and your confidence that builds over time.
Yeah, I would second pretty much the same thing. Definitely if a patient tells you, I don't do well with local anesthesia, listen, do yourself a favor. Just take that patient to the operating. If they're literally flashing the red lights in your face, doctor, I have a horrible time at the dentist. I don't do well with local anesthesia. The other one is I metabolize the anesthesia really fast. I'm kind of resistant. Yeah, don't even bother. Just take the patient to the operating room. And I think, certain disease states, allergic fungal sinusitis is not an office procedure, most of the time. And patients who have, disruption of the biome, chronic biofilms that need high volume, irrigation, hydrobreedment, you have definite fluid management issues in the office when you get over, 50 cc's of irrigant. If you're using one of the high pressure irrigation vacuums that the technology partners make, you can do a fair bit of irrigating and suctioning effectively. But like when you're talking about 4 liters of irrigation to blast out, there's no way. So those patients all need to be appropriate site of service. And then lastly, I would just second, there's a group of adolescent patients. It's frequently the adolescent, macho man or the adolescent females that tend to have some difficulty. And the older patients usually fall asleep, and they're the cutest, sweetest people. They wake up, usually you're waking up Mrs. Jones when you're finished after she's been snoring for 30 minutes. You're like, Mrs. Jones, you're done. And she's like, I'm done. What do you mean I'm done? I didn't even know you started. You're like, yeah, that's exactly how we want it. It's really a pleasure, and they're such sweet people.
Yeah. The scoping age adolescents they are tough.
Oh,
they are tough. You can't papoose them. We got papooses in my clinic, but we can't do that once they're past like 5. Like it's just, you can't. But the other, you can scope, best patients are under 6 months or over 60, but.
That's awesome.
All right. Really quickly, just one other kind of in terms of equipment. You'd mentioned having a cautery. If somebody wants to start, doing these procedures, what are like what do you definitely need to have?
I think, first of all, I think you have to put some thought into what's the room setup going to be. Obviously, the first thing you're going to need is a good endoscopic system, a tower that actually provides great transillumination, great visualization technology, companies that have these, and whatever you're comfortable with, whatever works for you. But that is a mainstay, a workhorse of what you're going to need. You're going to also need an appropriate camera to do the procedure, and then instrument trays. So over time, I guess I started with the basics, through-cut forceps, up and down, a giraffe forceps, and also a microdebrider, because you'll encounter sometimes, as we do in the operating room as well, a CT scan doesn't appear to have polyps, but then there are some polyps there. And although you can use through-cuts, I found that microdebrider just is able to take care of it so efficiently and effectively and very rapidly, which is important when you're in the office. You want to get the case done fairly quickly. So I think those are sort of very important parts of the equation. Obviously, disposables like a balloon dilation system for working with that. Then it depends on whatever else you're going to do. So if you're going to do revision cases that involve ethmoid work, a little more challenging cases, image guidance becomes important. And we added that on fairly early. And then, of course, like in my case, I have a septoplasty tray, similar to what we'd have in the operating room. We have different treatment options for turbinates, radio frequency energy, as well as microdebrider for turbinates. So that's kind of the equipment that I've developed over time. And I think you start with the basic workhorse, endoscopy and camera, and some, basic equipment tray that allows you to accomplish cases that are, if you're embarking on this for the first time, it may just be single balloon dilation and then progressing it after that.
I would say, a couple other things that maybe seem obvious or, maybe not even, somebody mentioned, but having a very comfortable exam chair that can recline is really, really important. One that's adjustable, because really your comfort and the patient comfort are tantamount. Having a high quality suction, making sure that your SMR cards are really suctioning well, because you need effective suction when you have an awake patient who's asleep. And those are simple, obvious things, but amazingly, they'll let you down and you'll regret it. And then, remember a couple other things for a new adopter who's just trying to get started, or maybe somebody fresh out of training who doesn't have, the luxury of a robust profit and loss and a lot of money coming in. This is where you leverage your industry partners. You literally say to them, listen, I want to get started. I need your help. I need you to bring in a demo for me for my first 5 cases. And I need you to let me try a couple cases with your balloon to make sure that this is something. So, you get a couple cases, and that's part of trialing the balloon, right? You get a couple free cases to check it out, decide which technology you want to use. They'll bring in a camera for you to demo. They'll bring in a tower. I mean, they'll bring in the mini fest set for, 3 or 4 cases. So highly recommend doing that. It'll generate some income. It'll generate some confidence. And then it'll allow you to really fine tune what you like, what you dislike, what you're looking for kind of for a more permanent fix. And, one thing I would just say, I mean, Dr. Sikand and I have a lot of interest together. We have a couple companies that we've built and we have a technology company. And so we're constantly developing tools. And so we're always thinking of the next thing in ENT. And we've got, we're one of the things we've worked on is a new kind of endoscopy platform. So I won't talk too much about it because that's beyond the scope of this, but maybe one other day we can come on and tell you a little bit more about it. But what I would say is that it's certainly one of the things we have in mind is that this equipment is extremely expensive and in some ways prohibitive to the young new otolaryngologist. And they're also that's very limiting. I mean, when you have to put something the size of a refrigerator, the tower and the cart into your exam room, and that takes up a lot of space. And it's against what we're preaching with an office-based, mobile, kind of cutting-edge platform. And so we were thinking about that when we created our newest innovation, which hopefully we can talk to you about sometime in the near future.
That sounds great. We actually BackTable has a whole innovation show. And so it would be great to get you guys on. Eric Gantworker is one of the hosts for that. He's a pediatric ENT. And it's something definitely I think would be great to highlight your story there. Y'all mentioned a lot of benefits in terms of working with industry, whether it's, having, when you're first starting out in practice, working with industry to help, get demos and help you get started. You talked about how sometimes they can, with new devices and techniques, you have to be open because that's where we kind of see the problems maybe we've missed before. But it sounds like also in terms of research opportunities, when you're starting something new and you have something in your practice, there's also research opportunities. What other benefits do you see, or why should physicians partner more with industry? I feel like we don't, in terms of in teaching in academic medicine, personally, it's not something that we tend to even, I think, talk to our residents about. I realize now it might be a little bit of a disservice if they don't know how to leverage that for their practice.
Well, I mean, for me, it's a really great question. I think it's a spot on question, especially for the modern graduating otolaryngologist. I mean, without industry, we wouldn't have the technology that we have today. There's nothing wrong with companies, wanting to develop tools to make money. And that's what drives our ability to have tools, right? What I would say is that just because an industry partner brings you a tool doesn't mean it's a good tool, but you should always at least have an open-minded evaluation and an assessment. And honestly, what I've learned with industry is that there's some incredibly intelligent, incredibly great people. One of the people that, probably one of the greatest influences in my entire career in medicine is a guy named Josh Mackauer. And Josh is he's one of the greatest medical device innovators in our country. He was the founder and creator, and now he's the director of the Stanford Biodesign program. All Josh does is teach young physician scientists how to innovate and how to build amazing technologies. And Josh was the co-founder of Acclarent, and I think he's founded and sold 7 medical device companies. He's only in his mid 50s. But without my kind of intro to industry, I never would have met him. We are really lucky to have industry focused on ENT. We've had 3 or 4 billion dollar plus market cap companies emerge in otolaryngology in the last decade. That's unbelievable. The only other fields that are like that, probably in all of medicine, are orthopedics and cardiology. I take my hat off to the academy because I think a long time ago, the approach from the academy was, industry is evil. We can't talk to those people. They're just trying to give us pens and bring us lunch and sell us stuff.
Well, you can't take a pen.
Right. Now you can't do that anyway. That's what I was going to say. So now they can't even bring us coffee without us having to report it. But what I would say is without those people, we wouldn't have the innovation that we have in our field. And to the academy's point, I think they've done an incredible job of embracing it. There's a guy named Ron Coopersmith, who was one of my residency classmates. And Ron is head of the program that interfaces otolaryngology with industry. And so I take my hat off to the academy. They've done a great job of trying to embrace that relationship and move things forward.
Are there any downsides in partnering with industry that you found in your experience, or things that a physician coming out or is interested in should kind of look out for?
Yeah, I would, within our training programs, and not just in the actual academic program, but in courses that we're trying to deliver to young physicians or physicians in training, we should probably develop in them or inculcate a sense of being able to critically evaluate technology. I'll look at it from the perspective of, the literature, look at it in terms of, does this make sense? Is it going to really improve the life of my patient? Is it going to deliver what it's supposed to deliver? So some critical analysis capability, I think, would be great. And I went throughout my residency program and we didn't really interface with industry. I think that's probably still the case to a large extent, at least as a resident. And when I was in fellowship with Rod Perkins at Stanford, he was also somebody who had innovated and developed a number of companies. My time there allowed me to be able to critically evaluate, or at least try to critically evaluate emerging technologies. So I think it's very important to absolutely have an open mind, but bring a scientific bearing and the bearing of a physician that has the best interests of the patients at the top.
Yeah. Well, thank you guys so much for taking the time to talk with me today. For our listeners, just remember what Dr. Weeks says, be open, don't poo-poo new techniques. And what Dr. Sikand said, you're never alone to advance through challenges, build your own team. Those are just some straight up life pearls, if you will. Thank you for swinging by if you're a new listener. And for our old listeners, thank you for returning. You can find us on SoundCloud, Spotify, iTunes, Apple, and Ghana. Please follow us on Instagram and Twitter @_BackTable ENT. We love feedback. Reach out to us for topics, ideas, speakers, or if you ever want to come on the show. It's a wrap. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson.
And Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Thanks again for listening, and see you next week.